report on that as we move in this afternoon to more brainstorming and how do we change everything that we've experienced. But in this session, we're going to explore at European level what can be done about this. And we're going to explore how we advance health for all, looking at European initiatives on racism and discrimination on health. And we have joining us online, I'm delighted to welcome Stefan Schreck, who's an advisor for stakeholder relations for DG SANTE, that's the part of the European Commission with responsibility for health. And we're also going to have Michaela Moua, who's from the European Commission's anti-racism coordinator for DG Just. So would you like to come and join us, Michaela? That would be great. Stefan, you're online. I'm going to invite you to be our first speaker and just to tell us, what is the Commission doing? What instruments do they have? Obviously, you work in health. So within the health, limitations, the sandbox that the health department has, what is your room, your instruments to target health and racism, and what initiatives do you have? Stefan.
Yes, thank you very much, Tamsin. Can you hear me?
Yes, we can.
Wonderful. Yes, well, I start with the beginning. In the European Union, everything needs a legal basis. And in this particular case, we are talking here about Articles 21 and 35 of the EU Charter of Fundamental Rights related to non-discrimination and access to healthcare. And I will just read them because they are really quite fundamental. Any discrimination based on any grounds, such as sex, race, color, ethnic or social origin, genetic features, language, religion or belief, political or any other opinion, membership of a national minority, property, birth, disability, age or sexual orientation shall be prohibited. So it's prohibited. And then everyone has the right of access to preventive healthcare and the right to benefit from medical treatment under the condition, and that's an important limitation, under the conditions established by national laws and practices. And then a high level of human health protection shall be ensured in the definition and implementation of all union policies and activities. Based on these principles, the Commission promotes universal health coverage and has enshrined access for everyone to affordable preventive and curative healthcare of good quality. That's one of the 20 principles in the EU pillar of social rights, together with the gender equality and equal opportunities, to reaffirm the commitment to put people first in Europe's recovery from the pandemic and beyond, and achieve the 2030 Sustainable Development Goals based on the same principles. But it's also clear that more needs to be done. And there was already this morning a reference to it. 2 weeks ago, the Fundamental Rights Agency published a new report, Being Black in the European Union, Experiences of People of African Descent. And this report really highlights some striking examples for the area of health. The 12 months prevalence of racial discrimination in using healthcare services has increased since 2016. That was the last report. It was actually 9% in 2022 compared with 3% in 2016. And around every 10th respondent, so 9%, responded that they had an unmet need for medical examination or treatment in the year before the survey. And this is nearly 2 times the rate in the general population, which is only 5%. So what is done about it? We had 5 equality strategies that have been adopted in the mandate of this college. There was the gender equality strategy, the EU strategy for Roma equality, inclusion and participation, the first EU LGBTIQ strategy, the EU strategy for the rights of people with disabilities, and the EU strategy for the rights of the child, followed, and then there's also, of course, the EU anti-racism action plan. And in all these policies, health and access to healthcare play an important role. Then, of course, we have the EU for Health program that supports health policies, including the reduction of inequalities in health, in synergy with other relevant union actions and funding instruments. And it contributes in this way to the attainment of goal number 3 of the United Nations 2030 Agenda, Sustainable Development Goals, ensure healthy lives and promote well-being for all at all ages. And to do so, the program recognizes the importance to address health determinants, including social determinants such as social exclusion and discrimination, without, however, detailing any of the reasons resulting in these situations. So it's not that specific. It doesn't mention racism, homophobia, ageism specifically. Yes, I think I will leave it here with my introductory statement. Just to say that I found the discussion already very interesting this morning, so I congratulate you for having this meeting.
Thank you very much, Stefan, and again for sort of reminding us that there's been 5 equality strategies, looking at different aspects. And I think we'll probably come back to you to invite more about how we address, intersectionality, because many of those different strategies will have a strong crossover. But let me first invite Michaela to reflect a little bit on, you are the anti-racism coordinator, so you have that oversight across the European Commission on what they're doing. We've just heard there's an anti-racism action plan, but maybe you might want to start by telling us a little bit about what's the understanding of structural racism at EU level, and then how that leads to the anti-racism action plan. Michaela.
Sure. Is it on? Is it on? Yes. Okay, great. First of all, to Mila and Raymond, thank you very much for having me here today, and congratulations on today's event. I'm really happy to see that these discussions about the link between racial discrimination, racism, and health are being more and more highlighted. Just congratulations, really. So on structural racism, when we think about the International Convention on the Elimination of All Forms of Racial Discrimination, which binds the parties to the convention not to permit public authorities or public institutions, national or local, to promote or incite racial discrimination. We start there, but thinking of the EU Anti-Racism Action Plan, it sets out the fight against racism really by centralizing the principle of structural racism. And the plan describes it as the underlying problem that's reflected in the way society functions, how power is distributed, and how citizens interact with the state and public services. It acknowledges that structural racism means moving beyond the individual level of racism and focusing on the structures in place that drive and sustain inequalities. So it's not, it doesn't limit itself to the sector of law enforcement, of course, which we know specifically when it comes to racialized people and communities is one of the problem areas, but all policy areas, including public goods, housing, education, the labor market, but also the health sector. It really means that not every individual that is working, that is in the societal system concerned in this sector is a racist, but that it's a structural issue. It's a systemic structural issue. Doctors were mentioned, the role of the doctors, but also on how the processes, for instance, how medication might be provided in Finland. What is known as it's called cultural pain in my native Finland. That's why I'm mentioning Finland. They call it cultural pain, meaning that there's assumption that for racialized people there's an over dramatization of pain, but also that they can are able to what's the word? They're able to take more pain in a sense. So of course this affects how you practice medicine. If this is one of the unconscious biases. Life expectancy was also mentioned. For example, overall health insurance is in place and accessible, but in general, life expectancy for racialized groups is significantly lower than for most of the population. We talked about stereotypes and prejudices, which were mentioned also with other speakers. These have historic roots, and they differ between member states, between different racialized communities, and they're very much intertwined with the national building narratives. For instance, when it comes to Roma, when it comes to people of African descent and Black people. And all of these affect how structural racism manifests in the area of health. And then data is, I think, really the crucial piece that we need to strengthen. The Commission is really encouraging member states to move towards a harmonized approach to data collection, where at least we are disaggregating data based on the six grounds that are in the treaties, one of them being racial or ethnic origin, and also in different policy areas, such as health, of course. The challenge is we're moving currently towards, in many member states, towards the invisibilization of race as a category, and using this universalist approach rather than actually it being seen as something too sensitive to ask, even though we know from research that has been done that if any group of people is clearly explained why such sensitive data is being collected, how it will be stored, what it will be used for, there's actually a willingness to give up this sensitive data. So the idea that marginalized, minoritized groups do not want to give up this information is not true. So maybe I'll finish here with my starting statement.
Great. Thank you very much. And it's at this point, I'm going to be also opening the floor to you for questions, but I'm going to start with a Slido poll to get us functioning, because we've heard from both Stefan and Michaela, what exists in the treaties, what exists in the sort of legal documents. What I want to see from you is, how do you see the European Commission's role in anti-racism and anti-discrimination in health? And perhaps that's, what could we do to, take these great documents that set out things, these 5 equality strategies, the anti-racism plan that's there, what should the European, or could the European Commission do to help transform this into something that's more practical? So by any means necessary, we've had a first message, find some workarounds. So, this is in health at European level, there's always this conversation where we start by saying, the EU has no legal role, and we're always dancing around that question. So, but given that, framework, what could the European Commission's role be in this to tackle it? And bear in mind, it's a whole range of areas that the Commission works on. So, informing health policy, using regulation and policy tools, being accountable to this. We talked a little bit about data, and I know that maybe we could touch on the European health data space, how that could be useful. Stefan, I'm also going to come to you because something really struck me about the messages that we had, particularly from Abby, who described the huge body of evidence about the impact of discrimination at a biological level, and talked about, the accumulation of stress and inflammation raises the risks of NCDs. Now, the Commission have action plans on NCDs. One of the challenges about NCDs, the non-communicable diseases, is those are seen very much as lifestyle related, and therefore somehow the individual's at fault. They don't eat properly, they drink too much, they smoke too much, and yet what we've just heard is that there is a biological impact of stress related to discrimination that increases your risk. So we've got that challenge there. And Jackie, I know you want to come in and make a comment. Do you want to see if your green microphone above works?
Yeah, I think it does. Yeah, okay. So, hi, Stefan. It's Jacqueline Bowman here. I mean, we've had these conversations. So I just need to step in again, wearing my day job hat as representing 20,000 plus obesitologists, so health professionals who are specialists in obesity. And I just want to give a bit of pushback here to say that obesity has been classified as a metabolic disease since 1948. We just happen, very long story short, to have missed the boat to be politically prioritized during the original NCD frame policy discussion in 2011, but we're well on the way towards having that rectified for 2025 and towards 2030. What's really important here, as well as previous speakers have said very nicely, thank you, Aoife, is actually making the linkages between things like cortisol, which is scientifically, medically known, along with stress and mental health, to depression, all the rest of it, as biological triggers to the biology of obesity. So I think it's really wrong to sit, literally inaccurate, for us to try and go through your old copy paste that the Commission finally is moving forwards and helping us rectify. So happy about that. But it's really wrong to sit there and use the old rhetoric, which actually we know is incorrect and legally speaking is unacceptable. So what we need to be talking about here, and that's why I'm so happy to see Michaela and others, we don't need to be talking about actually the health issues. We need to be talking about what are the legalities of access to health service delivery, because actually that's where the discrimination is at this point. And I'll have a lot more to say on that later, but I just wanted to push back and say, please stop the rhetoric on lifestyle. This is about biological triggers that make sure that people end up disproportionately in need of health service delivery that we're not accessing one way or another, and representing health professionals, my colleagues, my community is not being trained in order to be able to deliver that service, which is actually a legal obligation as well.
Thank you. Stefan, would you like to come in on this, looking at how, in the sort of areas of health policy and health strategies that you've got, this aspect of racism and anti-discrimination is addressed or not, and what could be done within those tools that you've got to raise the profile? Because amongst the feedback we've got in the Slido poll, one of the things they're saying is that what the Commission could do is connect health and anti-racism. You could ask the right questions, you could promote and require data collection, and support countries in their leadership. So we've got some messages of what we'd like to see the Commission do. Can you respond on that?
Yeah, I'm reading them with interest. Yeah, just a comment on the lifestyle. I mean, we prefer to talk these days about health determinants, indeed, one has to see the whole context here. But I'm really intrigued by the comments on what the Commission's role should be. Maybe I can have a screenshot of that list here. That's really interesting. What really I find interesting is to find workarounds. As I've pointed out already, the provision of healthcare is responsibility of member states, I think. And the treaty is very clear on that. And that means that also the member states are responsible to ensure equality in the provision of healthcare. And we've seen a nice example from Belgium already today. But one of those workarounds we can maybe use is the fact that the many regions of Europe, they are trying many new strategies to better deliver healthcare, and the focus is very often indeed on equal access to healthcare to everybody, including those who are usually discriminated against. And what we can do at European level, despite the fact that we can't tell member states how to organize their health systems, is to help them learning from each other. And we have actually established a very sophisticated system now to help everybody to submit practices which can be assessed as if they comply with criteria we have agreed with member states for a best practice, and can then be implemented in other member states with help from our EU for Health program. And we have also, for example, things like our health policy platform, where all the relevant health interested groups can work together and actually provide input to health policies, for example, which we can then in turn use to formulate new approaches. But in general, what I would really like to say after listening to you, in a way, you can say that the whole EU health policy, insofar as it is not for very specific areas, is about equality of access and the same level of healthcare for all. And that applies within member states, where, for example, we promote population-based cancer screening as opposed to opportunistic screening, which very often helps only those with a socioeconomic advantage. But also among member states, we have, for example, cancer screening in Nordic countries is much more successful than in some other EU countries. And so if you so wish, the whole EU public health policy is about reducing inequalities among everybody, essentially.
Thank you, Stefan. And we will, of course, send you a screenshot of the ideas coming from the audience about what they'd like to see the Commission do. Michaela, if I'd like you to perhaps have a look at that, and you can see that this is some suggestions of what the Commission could do. Now, could you tell us perhaps a little bit more about what's in the anti-racism action plan to see, does that cover some of the things that people are looking for from the European Commission?
When it comes to the section of health, I must say that the anti-racism action plan is not very strong. What we do have in there, and why language is very, very important, is that once we start getting certain language into Commission documents, because I work so closely with member states, I know that that helps to push member states to move forward, and because they can always refer to, but look what the Commission is saying, like now that we have structural racism actually in black and white in the EU anti-racism action plan, we can actually start working on anti-racism policy from that starting point. So it's huge. So the one thing that is very relevant in the action plan, I must say, is that it mentions that racism can cause mental health. So just to have that short sentence in there is much bigger than we think, because that's the starting point that we can then start pushing, or me as the EU anti-racism, the European Commission coordinator on anti-racism can start. That's my starting point. It's under my mandate because it's in the action plan, right? So language is really important. Secondly, we have to think about really, when we think about the role of the Commission in drafting, which is drafting drafting policy, proposing legislation, and funding, basically. I think these are still, regardless of it being on national competency or not, these are tools that we can use to, for instance, fund projects and actions in member states that are already kind of doing this work to ensure that, at least on the member state level, things are moving forward, even though it's because it is indeed the competency of member states. It's also important to remember what we mean when we say anti-racism. We have to realize that it's actually active identification and reduction of racism. It's done by changing and challenging systems, organization structures, policies, practices, legislation, etc., with the objective of true equality. So this really has to be the starting point. The one thing I'm very proud of that the Commission is doing is indeed the work on equality data. We are really working closely with member states to ensure that we get to a point where we get disaggregated, reliable, comparable equality data, at least on these 6 grounds that I mentioned that are in the treaties, using an intersectional approach, which I think is also extremely important in all areas, specifically in the area of health. And I think I just want to come back to something that was mentioned, I think, by Hans, that there's sensitivity when we talk about racism and health, and let's not hurt anybody's feelings, or the doctors, let's not be too. I think we need to get past that now. Like, people are really dying, suffering, their life expectancy is being cut short. We can't, this is not anymore an issue of let's be more politically correct with our words. We have to talk about the actual thing and not just dilly-dally around the thing, but actually talk about the problems, the challenges, and fix the structures, and ensure that people can have opportunities and live the lives that that everybody should be able to live.
Thank you, Michaela. I wonder if you could just briefly tell us a little bit about the history of the anti-racism plan, because not all countries across the European Union are as equally open and progressive to acknowledging the diversity of their European societies. And as you say, you know, when the language matters, when something's written in a European document, it becomes either a political priority or it becomes an obligation. It does act as a trigger for change. So sometimes member states can be quite uncomfortable about putting things at European level. So can you just give us a little bit of an insight on the pathway to having this landmark document adopted?
Certainly. I mean, so it's the first EU anti-racism action plan, which really came about due to the events of 2020 and the murder of George Floyd in the US and the Black Lives Matter movement becoming a global human rights movement. So May of 2020, George Floyd was killed, and September of 2020, the Commission had an EU anti-racism action plan. Of course, it didn't come from, you know, from nowhere and in a vacuum. Civil society had been advocated for years and years and years. So this is really also you know, big work done by the civil society to push the Commission to have a horizontal, solid policy tool to step up the fight against racism. But that's basically was the trigger. And it's a horizontal policy tool covering different areas. And I think still the most important thing in this policy tool, in addition to, of course, the 80 different actions that it has relating to education, digitalization, different legislative policy projects, health, youth, etc., is really the mention of structural racism. Because to move from looking at racism as an individual, something that happens between individuals and at an interpersonal level, to realizing that this is something that is in society and in structures and is systemic, and starting policy and legislation from that viewpoint completely kind of shifts the paradigm. And I think that is the biggest kind of addition that this policy tool brings. Of course, it's a very young file. It's only a toddler now, 2.5 years, 3 years. So the work has just started. What I'm trying to do under my mandate is I'm working indeed closely with member states to ensure that they have national action plans against racism that mirror, for instance, these principles of the action plan, such as structural racism, intersectionality, data collection, etc. But you're right, member states are coming into this from very different viewpoints, different contexts, different historical situations as well. But what we're trying to still move forward is indeed that even if there is not a large population of racialized people or Black and brown people in a given member state, there is still racism in all parts of our society, and all member states should still have national action plans against racism that, of course, fit to their historical context.
Thank you. Do we have any questions or comments that people might like to make from the floor? Yeah. Do you want to try speaking, see if the green microphone picks up?
I think I can speak up. So my name is Raymond Gemen. I work at TIFA as a head of policy. And I have a question for Stefan. First of all, thank you for being with us here today, Stefan. For us, it's really important to also have DG SANTE around the table. And I will mention later that earlier this year, I have presented to you our joint statement of the DISCO thematic network. And I know that, and I understand that this statement was, you know, kind of a summary, a common position of the network that you as DG SANTE have facilitated. But my question is more, I mean, anti-racism also starts with people, right? People speaking about the topic to create these safe spaces. So my question is really, after we presented this earlier this year, has there been any, I don't know, chit-chats, even at the coffee machine, about the topic of racism and discrimination within DG SANTE? Maybe that didn't work.
Stefan, did you hear the question?
Yes, I think I heard the question. Yes, it was about our coffee breaks and what we talk about.
Well, we want to know if it created a buzz.
Indeed, we do discuss this in our coffee breaks, even though I have to say they are not as frequent as they used to be in the past, when before Corona, when there was no telework, actually. And you can actually see, for example, results, if you so wish, in our communication on the comprehensive approach to mental health. The effect of racial and ethnic discrimination on mental health was specifically emphasized. So I do think that actually everything that comes out of DG SANTE on public health now will have this element included, because I think another element of this is that we have also understood that it needs to be included in any specific piece of recommendation. We had in the past, for example, a joint action on health inequalities to address them separately from the political issues which we have been promoting in parallel. And now we rather try to ensure that each specific act or each specific policy or each specific recommendation that we promote is shaped in a way that all the potential reasons for inequalities are addressed in the document. And we also try to translate this later on if, say, as a follow-up to a communication, we have a project which is called Joint Action, that member states in their work to implement this policy also take this into account. That's a new approach, if you so wish. And of course, the input you are referring to of the DISCO had a role in that. And we were actually discussing it even in coffee breaks. Yes, I can confirm that.
Thank you. That's good to know. As we draw this session to a close, Michaela, I'm going to invite you to reflect us for a minute. You mentioned that the EU anti-racism plan was put together very quickly after the trigger of the sort of immediate response to the killing of George Floyd by policemen in the United States. And it's as you say, it's a toddler, it's brand new. Next year, we're about to have the big game of musical chairs. New College of Commissioners, new MEPs. What do you hope will be the legacy of this mandate? You've got the action plan, but what do you hope will be maintained and continued as a new set of people come around the table? Their to-do list is going to be very long, clearly. What do you hope will be the legacy?
Tough one. Well, first of all, this action plan goes until the end of 2025. So it goes beyond the after the new parliament and college come in. There's still some time until the end of the action plan. Listen, I mean, what I'm trying to do really during my mandate, because it's a new file of the commission, is I'm really trying to put in place structures to ensure that no matter who's in this role, the work can move forward in a sustainable way and keep growing. I think that's relevant for any human rights, fundamental rights, equality work, is that regardless of who's going in and out, is it more right leaning or left leaning, center leaning, that there's still structures in place that ensure that the work goes on. So that's really what I'm trying to ensure during my mandate. I'm trying to ensure that there's a strong dialogue with civil society and other relevant stakeholders to ensure that the voices, especially of marginalized people and communities, get heard, and that they're part of every single part of the policy cycle. I think that's going to be very important. I really think it's crucial to make sure that the anti-racism is mainstreamed into all EU policy, that it's indeed, as Stefan mentioned, it needs to be something that's considered in every step of the way, the same way as gender is considered. Also, the anti-racism needs to be mainstreamed into policy, legislation, funding, and I think at least if I can do these three things, I think that would be quite a good legacy.
I think that's very ambitious, and I think that is an excellent legacy. And I'm absolutely certain with the kind of commitment and drive that you have, that you'll be able to achieve all of those things. So I'm going to bring us to a close because I'm sure everyone would like.
Stefan wanted to give another.
Stefan, yes, please go ahead.
Yeah, just one thing, because it's interesting. We have started last year to establish a European Cancer Inequalities Registry that tries to uncover all the reasons why cancer patients are not treated in the same way. And this will, of course, need several years to be developed. But I do think, as many people have actually deplored the lack of data, this can really be an EU initiative to collect more data, which can be useful for policy development in the future. And that is something which didn't exist before. We had, of course, cancer registries, which were about cancer cases, but which didn't do a lot actually to improve the detection of inequalities. And we have now this Cancer Inequalities Registry. And if anybody is interested, just send me a message and I can give you more information.
Excellent. Thank you very much. And Stefan, before I allow you to go, on that same issue of data, we have the European Health Data Space. I know it's being developed, so you probably can't give a final answer, but is the issue of collecting or somehow identifying, racial disparities, is that being thought about in the construction of the data space?
I think I can't really second guess my colleagues here, but I do think that in any case, this health data space will offer an enormous opportunity to collect also data on the causes and effects of discrimination. It is actually an open system for all sorts of health-related data, and it also responds to this issue which was already mentioned, that the national statistical systems, they are really having problems already to cope with the collection of data they are supposed to to collect today, let alone further additional data. And then that's why we think it's very promising to have a different mechanism to also collect data. I don't think that what kind of data can be collected and managed in this European health data space is defined already too well. This is part of the political process, actually. So it's also important that anybody who has an interest in that expresses their opinion to the institutions involved in the political process here. Yeah, and let me also say, while we are at data, we have, when it comes to communicable diseases, we have the European Center for Disease Control, and the member states' health ministries provide directly, or health authorities provide directly data to the ECDC on communicable diseases, but they don't do this for non-communicable diseases, for example. Neither for any data around communicable diseases like causes and effects of discrimination here. And we hope very much that the health data space can also help there. But it's a very novel concept, and we will have to see how it develops. And on this, please make your voice heard in the mechanisms which DG SANTE offers for that purpose.
Okay. Thank you very much, and also for that open door for people to express an interest. And I think you've given us a really good, we'll pin it on the wall as a post-it, advocacy action. After the lunch break, we'll be talking about how to translate some of these, ideas into practical policy recommendations. So thank you for that, both to Stefan and to Michaela. And now I'd like to say thank you to you, both online and in the room, for being patient with us. We've kept you a while. I'm sure you're hungry and want to move around. For those of you who are here, there is lunch just outside this room. For those of you who are online, please enjoy whatever lunch is available to you there. We will see you in 1 hour. We'll start at 1:30 promptly. So thank you very much. Thank you, Michaela, and to Stefan.